This is Chronic Care Case Presentation by Summer Ellingson. So, introduction. My patient, her initials are JZ. She's a 69-year-old Caucasian female. She lives in rural Minnesota. Her previous and existing diagnoses prior to me seeing her for the first time. She has a history of hypertension and currently has hypertension. This is controlled. Hyperlipidemia, this is controlled. Prediabetes, also controlled. History of prediabetes. Class 2 severe obesity, uncontrolled but stable. She's working on it. A history of thyroid cancer requiring a thyroidectomy um, and supplementation. And this is uncontrolled. She was on Synthroid 175 mics prior to seeing me. And then coronary artery, she had a heart screen and had coronary artery calcification on her CT scan. And this is stable. She takes 81 of aspirin daily and doesn't have like there wasn't enough calcium to do a heart cath on her, and she hasn't had any heart symptoms. She doesn't have leg swelling. She doesn't have chest pain, that kind of stuff. So we're just monitoring it. In regards to her hypertension too, it is controlled, but she's on quite a lot of things. She's on 10 milligrams of amlodipine, 20 milligrams of enalapril, 25 of hydrochlorothiazide, and 100 milligrams of metoprolol. So she's on quite a lot to get her blood pressure controlled. So that's just kind of something to think about. And then for her hyperlipidemia, prior to me seeing her, she was on 20 milligrams of Crestor. And then in regards to her prediabetes and her obesity, she was on Contrave prior to me seeing her for the first time. And then pertinent social history, she's married. She has three living adult children, has a history of an associate's degree, which she used to work for the local school district as an early childhood educator. She's now retired, though. For fun, she likes to read, garden, and see her family. She drinks alcohol socially, doesn't use drugs, and has no concerns for STIs. Okay, so I first saw her like really early October-ish for her Medicare annual wellness visit. Vital signs wise, everything looked great. Something to just kind of keep in mind, she's 5'1". When I first saw her, she was 208, so her BMI was 39.49. But otherwise, everything else looked great. Her blood pressure looked good. Her physical exams looked good too. Everything, I'm not going to read it all for you, but everything was fine. Nothing, nothing crazy. Regular rate rhythm, S1, S2, no murmurs. Lung sounds were clear. Um, with the added weight gain, though, musculoskeletal wise, everything was fine. And then she also declined a breast and pelvic exam at this visit. So after, I saw her and the things that I ordered a TSH to check on her Synthroid dosing. And just a reminder, it was 175 prior to our visit. And so that came back low. I also ordered a hemogram. Her RBC came back low and her MCV and MCH were elevated. This, uh, I thought maybe it could be related to the hyperthyroidism. I didn't look too much into it. It was very hardly off. This was the first time it's been off, so just something to watch for. Her lipid panel looked good. She's on that Crestor. It looked good. CMP. So her creatinine was 1.4 and her GFR was 41, and then her glucose was 109, but this wasn't fasting glucose or fasting lab. So that was okay. But those kidney labs kind of shocked me a little bit. So that's just something to keep in mind. And then an A1C, and that was 5.2%. So that was good. So again, diagnoses prior and after. So she still had the hypertension. She still has hyperlipidemia. But those are both stable. Her prediabetes essentially resolved, her that 5.2%, so that's good now. Um, and then she still has these things going on. But the new thing, given that kidney function, the only thing that well, I didn't quite diagnose it, but an AKI versus like a CKD, either way, like decreased kidney function, it's kind of hard to diagnose both because I hadn't checked, she hadn't had her kidneys checked since last year, so it's hard to like have that 3-month lowering to actually diagnose CKD. And then same with an AKI, like I don't have a baseline creatinine since last year. So either way, it's hard to diagnose either. But regardless, she has decreased kidney function right now. And it was kind of a sharp decrease. Her creatinine was 1.03 last year, and it's 1.4 this year, and her GFR was 59 last year, and now it's 41. I'm leaning towards like a CKD, just she has that history of hypertension. She has a family history of cardiac disease. Just she has that history of prediabetes. She's obese. She has a lot of things going on that could link to CKD. I did look through her imaging, and she did have a history of like a renal artery um, imaging, given that like high blood pressure history, and that looked fine. But so this is just something we're going to monitor, and we're going to repeat labs in 3 months in December, and we're going to see if it's going to go back to baseline. Then it was just kind of a fluke. If not, then at that time we'll refer to nephrology, given all these things she has going against her and these worsening kidney labs. So referrals, also as I was doing my chart review, I noticed she had imaging done. She had an MRI of her abdomen with MRCP back in 2023 that showed a pancreatic um, mucinous tumor, if that's how I pronounce that. Well, it was suspected, not for sure, and the radiologist said consider a gastroenterology referral. She's had no follow-up for this since, or no repeat imaging. She hasn't seen the gastroenterologist, so I did put in a referral to gastroenterology and explained to her why. But like I was talking about in the previous slide, I held off on putting a nephrology consult in regards to her creatinine and GFR just because these were her first very abnormal levels. Like I said, she had a 1.03 last year and she had a history of a 1.02 2 years ago. So we're going to recheck this at our next appointment, a 3 month recheck end of December. And if it's still very abnormal, then the referral will go in. Um, and something else that I kind of thought about, she's never been to cardiology besides doing that $50 heart screen she did. And there was some calcification that was shown. She does have a family history of heart disease. She remains on her Crestor and she has that baby aspirin. She has no symptoms of heart disease. She doesn't have chest pain, dizziness, leg edema. So we decided to hold off on the referral for now. But this is something we could consider in the future, given like she also has those comorbid conditions of hypertension, hyperlipidemia, the history of prediabetes, she's obese, and that family history. Um, and then on a side note, because she is on that weight loss journey, her referral was placed to PT and dietetics to help her with that. So medications that I adjusted given these labs. So her Synthroid was decreased from 175 to 150. We'll recheck that TSH in her follow-up in December. So that'll be about 7 weeks. This is early October. So 7 weeks to 3 months-ish. It's a standing order, so when she gets time, she can go on and do it. And then I also increased her Crestor from 20 to 40. Given all that history we just talked about, and even though her lipid panel looked good, her ASCVD was still elevated. So I increased that. And then the Beers list and the de-prescribing, no medications were de-prescribed at this visit. And then just healthcare maintenance stuff for her. She's up to date with her mammogram, colonoscopy, her DEXA. Those all looked good. Her immunizations besides the flu were up to date, so that's good. And then the flu shot was given to her. And she has aged out of pap smears, and all of them have been normal. So the patient is going to follow up when we have an opening, but November, December-ish for her weight management visit. So between that first annual wellness visit and our next visit, she didn't have any hospitalizations. She didn't need any communications prior to us saying, like, these are your labs and this is what we're doing for medication adjustments. Nothing got worse in regards to like her heart health or kidney health. I mean, we didn't take labs, so we couldn't see it, but she didn't feel any worse. Um, she continued to work on weight loss. She saw and continued to see PT. She met with a dietitian. And she did schedule to see gastroenterology, but can't get in until after the new year. So, visit number 2 was a continuation of her weight loss because she was also being seen for weight loss. And so this was the end of November. She got in. And so her blood pressure a little more elevated than last time, but still not bad. She lost 5 pounds. Her BMI is down to 38.36, so that rocked. Um, Same physical exam looked great. Nothing changed. Nothing new. Medication adherence, like I said, the patient has been on Contrave, Wellbutrin, naltrexone, 150 and the 50, extended release. She was having nausea, but the dosing was changed from twice daily to the extended release once daily, and that helped immensely. So overall, not just this visit, but overall, her start weight when she was first seen for weight loss was 242. And like I said, when I saw her this day, it was 203. And then, like I said, she lost 5 pounds since I saw her on her annual wellness visit. And in general, her goal weight is 140 pounds. So, adjustments to care. She has a history of being on Ozempic, but it was not covered any longer. I don't quite know the date when it stopped, but so she hasn't been on Ozempic for a while because of insurance reasons. So she continues on Contrave for now. But given that Wegovy was FDA approved to help prevent life-threatening cardiovascular events in adults with cardiovascular disease and obesity, we resubmitted to see if her insurance would authorize a pre-auth for it, giving, she has that coronary calcification and her comorbid obesity. She's at higher risk than the average patient for cardiovascular death, heart attack, and stroke. So we're waiting to hear if that will be covered. Um, so at this visit, again, contemplated giving her a cardiology referral at this time, thinking hopefully it would help get Wegovy covered if they do find something. But again, she continues to have no symptoms. She's symptom free. So hold off for now and just see if insurance improves Wegovy or not. If not, again, in the future, we can reconsider going there. So some cone sheet techniques at this weight loss appointment discussed in detail and reinforced obesity treatment education, counseling, and resources to optimize nutrition, physical activity, sleep, and psychosocial health. Nutrition recommendations reviewed and an emphasis on moderate high protein intake for preservation of lean mass, high fiber, low moderate intake of carbs, and primarily from vegetables and whole grains, and to eat healthy sources of fats. Excuse me. Reviewed the importance of establishing long-term sustainable eating patterns, learning to eat to fuel the body and eating until no longer hungry rather than eating till full. We reviewed and discussed the importance of activity, including non-exercise activity thermogenesis, so like losing weight or like activity regards to activities that aren't just working out, like walking and walking your dog and cooking and doing laundry, things like that. But also resistance training 2 to 3 days a week, and aerobic activity 3 to 4 days. Excuse me. Weekly. We also reviewed the carb manager, which she's been using. So she's been doing great. She's lost a lot of weight so far. But also just like things that were used motivational interviewing, like I expressed empathy for how hard it is to lose weight, but congratulated her on her self-efficacy and progress this far. Smart goal setting, like realistic weight loss increments, even if it's just like 1 or 2 more pounds at her next 12-week follow-up. The teach back method, like tell me what your diet is going to focus on this week, whether it's less carbs or, whatever. Regular follow-up and accountability. So like I said, every 12 weeks, she gets weight checks and visits, and then just positive reinforcement, like celebrating the small wins, like the 5 pounds she lost. So conclusion and discussion, ethical considerations or autonomy, she has the right to make her own decisions, choosing to not follow up with GI, for example. Benefits and non-maleficence, acting in her best interest while avoiding harm. So assessing for the potential to overtreat while also the potential to undertreat. Justice, providing equitable care despite her geographic or resource limitations. So advocating for her to access these specialists and transportation if needed. And then just confidentiality. Living in this rural area, news about people spreads fast. So just keeping your visits confidential is a big thing. And then cultural considerations. So that rural Minnesota context, every referral you make means she has to drive to get there. Um, so just keeping that in mind, especially given her economic context as she's a retired educator, so she lives on a fixed income. So, driving costs money. And then also rural living tends to mean a slower pace. And so I find that some of these people, when they come to the clinic, it's also a little bit of a social aspect. So not just like rushing through their visit, but also giving them just that social piece they really enjoy. And then a generational context, just like technology and adaptation to that technology, just, being aware, like, is she on my chart? Is she actually using it? Does she check it? Would she rather me send her a letter with her results or call her? So just those are things to keep in mind. And then aging in a rural area, just in general, sometimes seniors, I feel like, can experience geographical isolation if they're rural. So, but at the same time, they have their community and a lot of older people have their church. So just things to think about to help mitigate that loneliness. So yeah, these can all play a role in her decision making. In general, however, with this patient, it was kind of a straightforward two visit. She's independent. She does have chronic illnesses, but they don't impede her ability to think or care for herself. Um, there's no language barriers. Thinking of her chronic illnesses impact on her, she has a complex web of physical, emotional, and social challenges. Um, she may face a greater difficulty in managing her conditions as they progress, especially if that is kidney disease that's starting to progress. Experience reduced quality of life and encounter significant barriers to improving her health due to the interconnectedness of her obesity and all these chronic conditions. But addressing both the physical and mental aspects of these conditions is essential to, excuse me, improving her overall outcomes for this patient. Um, And feelings of powerlessness do come, with these chronic conditions. But I think I got the vibe that with her weight loss, she's starting to feel a little bit more in control, but I feel like the more weight she loses, the more in charge she'll feel. So we'll see. Developmental level, she's at Erickson's integrity versus despair. It's the older adulthood from 65 till death. It's the eighth and final stage, and the major question is, did I live a meaningful life? So integrity versus despair involves a retrospective look back on life and either that feeling of satisfied, like a life was well lived, or regretting choices and missed opportunities. So that's just something to think of. And then I might pronounce this wrong, but Piaget's, she is formal operational, fourth and final stage. She can reason abstractly and think in hypothetical terms. So end of life planning, she did have an up-to-date advanced directive, and I know that because I had to look at it for her annual wellness visit. But she's not, on hospice or anything, so nothing was too focused on that. In terms of care coordination, we had those follow-up visits scheduled, so nothing be needed like beyond the regular visits or follow-up. But I could see how, if she just needs to go to nephrology, cardiology, gastroenterology all in the future, it could seem to be a lot. And so like just having like a nurse care coordinator for her because of her all of her chronic conditions, that could be helpful. The community resources she utilized, it's a local, just like the school gym is free to the community. Utilizes that. And then she goes to a local PT place for her PT. Unique contributions I made. Honestly, I don't think I made any great contributions that nobody else could have made, besides just being a new face person for her to talk to. Like I said, you could tell she enjoyed the social aspect of the visit. So what would I do differently? When her TSH came back, I probably could have investigated just like her synthroid taking habits a little bit more. And then I could have maybe addressed why she didn't follow up with a gastroenterologist in 2023 further. But there's just such limited time when you're doing an annual wellness visit that you don't have time to, address every single thing. And then maybe, I don't know, talk about kidney disease more, but I didn't want to scare her, especially because we're just monitoring it for now. But I do think someone, whether it's my preceptor, the clinic nurse, or I, should have called her prior to her lab only appointment. Should call her prior to her lab only appointment coming up here in um, December when she's getting her TSH and BMP recheck to see how she's doing, if she's having any symptoms of thyroid or kidney disease, just to make sure she's okay. And these are my references. Thank you for listening.